My name's Angharad Davies. I'm a clinical academic microbiologist at Swansea University Medical School and also Health and Care Research Wales Specialty Lead for Infection. The work I'll describe here was carried out in my capacity as a member of the British Medical Association's Medical Academic Staff Committee and COVID-19 Advisory Group. Very early on in the UK COVID epidemic, concerns arose about the impact of this disease on Black and Asian minority ethnic NHS workers. The first 10 doctors to die of COVID-19 in the UK were all from a BAME background. Further analysis over these early couple of months continued to be a cause of concern and was widely reported. The BMA had quickly established a COVID-19 advisory group at the start of the UK outbreak, of which I'm a co-opted member. Obviously, the group was extremely concerned about this issue. The early data, which did have limitations and a risk of bias because of the ways that it could be collected, was showing that around 2/3 of deaths in nursing staff were in BAME nurses and 95% of the deaths in doctors were in doctors of BAME backgrounds. Intensive Care National Audit and Research Centre data also showed that 34% of critically ill patients on ITU for COVID-19 were from a BAME background, compared with only 17% of the general population. And whilst NHS staff of a BAME background comprised 21% of healthcare workers, they made up 63% of those healthcare workers who had died. The reasons for this are very complex and have still not yet been completely unpicked, and they were even more unclear at that time. Proposed reasons then included the possibility that there were a higher prevalence of comorbidities in this group, for example, diabetes, deprivation and/or childhood poverty, being more likely to work in occupations with a higher risk of COVID-19 exposure, being more likely to use public transportation to travel to work, or discrimination. Since the start of the UK epidemic, the BMA has been carrying out regular surveys of doctors' experiences. And these surveys have found that in addition to any other issues relating to comorbidities and deprivation, BAME doctors have felt less confident to raise concerns about their safety than white doctors and more likely to feel pressured into working in settings with inadequate PPE. The BMA called for a system of risk assessment for doctors to take account of factors including ethnicity, and the COVID-19 advisory group recognised very early on the need for an individual staff risk assessment tool, separate from a risk assessment of the workplace. Work on this started in April. At around the same time, the Faculty of Occupational Medicine also raised concerns about deaths amongst BAME healthcare workers and called for a risk assessment framework for healthcare workers, pointing out that risk assessment of the workplace and also of those who may be most at risk is required by law under the Health and Safety at Work Act. So we undertook a review of the published literature to explore the relative risk of mortality from readily available demographic data at that time in order to identify the population at highest risk and incorporate them into a biological risk assessment tool using data sources that predicted admission to ITU and mortality in the UK population. The risk assessment tool first appeared on medRxiv on the 9th of May, and immediately we heard of trusts and health boards adopting it for use. This table shows the main body of our risk assessment tool. It was compiled using a Caucasian female aged less than 50 years with no comorbidities as a reference. Each point allocated to risk factors was associated with an approximate doubling in risk. And you can see that different risk factors confer a different number of points. These points can be added together and serve to stratify staff members into low, medium or high risk brackets. For staff at high risk, employers should consider redeploying them to lower risk clinical areas or to roles in which they can work remotely. The risk assessment tool was validated against the Open Safely data, which became available as a preprint around the end of April, although the final publication was in July. Open Safely was by far the biggest analysis of risk factors for death with COVID-19, including over 17 million NHS patients and over 5,000 deaths. The study found that people from Asian and Black ethnic groups are at markedly increased risk of in-hospital death from COVID-19. And contrary to some prior speculation, this was only partially attributable to pre-existing clinical risk factors or deprivation. That analysis found that increasing age, represented by the top 4 data points here, is by far and away the biggest risk factor. But BAME background, shown in the red box here, was a bigger risk factor than a number of comorbidities such as controlled diabetes. The tool was subsequently published as the BMA's risk assessment tool and can be accessed from the BMA website. On the 29th of April, NHS England had advised that employers must provide risk assessments for staff, and NHS employers were reminded of this again in June and told to complete risk assessments for at-risk staff by the 22nd of July. Despite this, by the 17th of July, according to a survey by the Health Services Journal, over 25% of BAME staff had still not had a risk assessment completed. Surveys have identified a number of obstacles and disincentives to risk assessment on the part of both employee and employer, and these have included, for example, the fact that risk assessments must be carried out with the line manager rather than occupational health, and some staff feeling uncomfortable about disclosing personal health issues to line managers, staff declining risk assessment for fear of being removed from clinical duties. Often there was no real plan in place to replace staff if they were removed from frontline work, and this was a disincentive to both employee and employer. And some staff reported feeling that this was only lip service and wouldn't result in meaningful action. The much-awaited Public Health England review of disparities in risks and outcomes of COVID-19, published in June, found that the highest age-standardised diagnosis rates of COVID-19 per 100,000 were in people of Black ethnic groups and the lowest in white ethnic groups. The report pointed out that the explanations were likely to be complex and relate to socioeconomic, occupational, health and structural inequalities. This is data from the Public Health England report showing the age-standardised mortality rates in lab-confirmed COVID cases by ethnicity and sex. Further analysis of survival after taking into account all of sex, age, group, ethnicity, deprivation and region found that when compared to white British ethnicity, people of Bangladeshi ethnicity had twice the risk of death, and people of Chinese, Indian, Pakistani, other Asian, Black Caribbean and other Black ethnicity had between 10 and 50% higher risk of death when compared to white British. Also in June, the Welsh Government published its own risk assessment tool, which partly drew on the BMA model. It again stratifies staff into low risk, high risk or very high risk, and for those in the very high risk group, it recommends non-patient facing roles where possible in a COVID secure workplace with 2 meters social distancing in place. In late August, it was reported that the guidance had been relaxed somewhat by Welsh Government to reflect the latest data and infection rates. At the time of recording this presentation in September, cases are on the way up again in Wales, so it's clearly going to be critical to continue to keep this under review. Acknowledgements are due all the other authors of the BMA Risk Assessment Tool and the BMA COVID-19 Advisory Group. Thank you for listening.